Good evening. I'm Jennifer Rabb, and I have the enormous privilege of serving as the president of Hunter College, where the American dream continues to come true a century and a half after our founding. Thank you for joining us tonight for the third program in our new online series, Speaking of Justice, Race, Racism, and Reform. This series was conceived as one element in our strategic recommitment to confront all forms of systemic racism and to expand opportunity at Hunter College and beyond. Hunter is seizing this moment to present important discussions like this one, which include the chance for students to participate in breakout sessions and conversations as part of an ongoing strategy to pursue a more just and more equal tomorrow. Such dialogues, we believe, help us toward fulfilling our historic commitment to the Hunter College motto, Mihi Cura Futuri, the care of the future is mine. Toward that end, last Thursday, we hosted an exploration on the fraught topic of monuments and symbols. The panel dove deep into the issue of removing Confederate statues and flags and spoke up for the power of new monuments to honor the heroes of African American history. At our premiere offering a week earlier, our panel explored the history of protest movements and the impact of protests on both consciousness raising and real legislative change. These were truly extraordinary discussions, offering insights about the past as well as inspirations for the future. And I urge those of you who may have missed them to look for them on our Speaking of Justice website. I want to express my deep appreciation to everyone who's contributed to these incredible conversations and to our extraordinary Hunter production team. John Rose, the Dean of Diversity at Hunter College, Misha Smith of Hunter's Director of Student Life, Malky Schwartz of the Grove Program at Roosevelt House, and the Jonathan Fanton Director of Roosevelt House, Harold Holzer. While we miss gathering on campus for face-to-face civic engagement, this online series provides a vital alternative and the chance tonight to explore a topic that touches on both the crisis facing our community and our country, the twin pandemics of systemic racism and COVID-19. The discussion is entitled Healthcare for All, Confronting the Racial Divide. We presented at a time when the healthcare disparities in our society could not be more apparent or more dire, as communities of color continue to be disproportionately impacted by this pandemic. While inequalities throughout society are laid bare under the cloud of COVID-19, in employment, housing, criminal justice, food security, education, nowhere is the inequity more dramatic or more dangerous than in access to prompt testing and quality medical care. Tonight's discussion will be led by Hunter College professor Phil Alcaldes, director of our respected community health program. Phil is the author of a 10-year-old book that all but predicted the conditions under which we are now living. Dread, How Fear and Fantasy Have Fueled Epidemics from the Black Death to Avian Flu. Since the beginning of the current pandemic, Phil has provided a guiding voice for the Hunter community and beyond, as a featured guest on podcasts and with his articles for publications like The American Scholar and regular contributions have earned him a reputation as one of the few lights in the darkness. He has brought a clear-eyed focus to critical topics like the failure to learn the lessons of past epidemics, including the AIDS epidemic, on which he conducted leading research throughout the 80s and 90s. In his most recent essay, he all but charted the course for tonight's conversation, and I quote, "To say that Black Lives Matter is to take issue not only with police violence or police beatdowns, but with all forms of our public health apparatus." We are so grateful to have Phil here with us tonight, and we thank him for leading this important conversation. Joining him is another star of the Hunter faculty, Dr. Michael Lewis, professor at the Silberman School of Social Work and a Roosevelt House faculty associate. As a teacher, social worker, sociologist, and former community organizer, Michael applies an analytical lens to society's most entrenched social challenges. His widely published scholarship takes aim at addressing the significant disparities that affect society's most vulnerable populations. His work has garnered international acclaim, particularly in the area of basic universal income. Thank you for joining us tonight, Michael. We are also lucky to have with us one of the city's most respected and beloved health administrators, Dr. Lilian Barrios Paoli. Trained as an anthropologist, Lilian has taught in Hunter's Eva Caston Grove Fellowship Program and in our Urban Affairs Department. An invaluable advisor to the college and a veteran of New York public life for over 4 decades, she has unparalleled experience spanning the highest levels of city government, the nonprofit and private sectors, and, of course, higher education. She has been commissioner of the city's Departments of Employment, Personnel, Housing Preservation and Development, and Aging. During Mayor de Blasio's first term, Lilian served as Deputy Mayor for Health and Human Services. She is also a former director of Lincoln Hospital in the South Bronx and the former chair of the New York City Health and Hospitals Corporation, the largest municipal healthcare system in the country. Lilian, thank you for the example you set for our students and the leadership you provide our community. Last, but at no means least, we're so delighted to welcome back to Roosevelt House in Hunter, Commissioner Osikiri Sparbo, New York City's Commissioner of Health and Mental Hygiene. As a member of the mayor's response team, she has been a consistent presence during this daily press conferences, helping to guide the city's response to the most complex and critical public health crises in its history. She has been a steady and strong voice for the caution and care needed to keep New Yorkers safe and, at the same time, has stood up for the safety of healthcare workers and other first-line responders. Dr. Barbeau has over 25 years of experience in health equity and urban health care. Commissioner, you are a valued member of the Hunter family. We are grateful that you have returned to be with us tonight and that you have given this time, especially during your tough schedule during the pandemic. Thank you for being with us and sharing your thoughts. Let me end by noting that we come together tonight not long after the passing of legendary civil rights icon, Representative John Lewis, the conscience of Congress. And we feel a special connection to this great man. He once generously graced us with his presence at Roosevelt House at Hunter College to discuss the progress of the civil rights movement he helped to lead for so many decades. In his eloquent remarks, he spoke of the righteous indignation that drove the progress of the movement, but still left people behind without adequate access to education or health care. Tonight, as we continue this discussion, we remember his words, his warnings, and his example. So now, please join me in welcoming our distinguished panel. It's a pleasure to turn tonight's proceedings over to our moderator, Professor Phil Alcalbes. Thank you.
Well, thank you so much, President Raab, and thanks to Harold Holzer, the terrific, although invisible, Roosevelt House team. I'm going to reintroduce the panelists because this is our special secret signal for them to light up, pull the curtain, and show themselves to you. Dr. Osiris Barbeau, the Commissioner of Health and Mental Hygiene of New York City, thank you so much for joining us. My beloved colleague Lilian Barrios Paoli, Senior Advisor to President Raab, and another beloved colleague, the esteemed Professor Michael Lewis of the Silberman School of Social Work. So, you know, seems to me that these times are so filled with anxiety and anger that I thought that what we ought to talk about is something that I feel is essential to public health, and that's the idea of belonging. Some of you know, maybe some of my students have been brave enough to join in. I teach courses here on medical sociology, social disparities in health, social structure, and health. And I notice that in public health, in the field of public health, and not only the field of public health, it's common to talk about racial disparities in a way that's like Black Americans are more likely to have hypertension than white Americans, and then let's discuss. I have a different view. I hold that Americans today construe health as, or sometimes I like to call it healthiness, in a way that's fundamentally exclusive. That to talk about racial disparities in health begs a series of deeper and much more troubling questions about belonging. Some time ago, about 25 years ago, there was a really brilliant and important book by the historian Georgina Feldberg called Disease and Class. And it was about the terrible public health problem of a little over 100 years ago, which was tuberculosis, leading cause of death in many American cities. New York City, by the way, to its credit, always a leader in public health, managed to make tuberculosis only the second leading cause of death around the year 1900. Still, it was a scourge, particularly for the urban poor. And what Feldberg observes in her history is that the response to tuberculosis, you might catch some of the resonances to our own time here, was shaped around drawing distinctions between the people who got tuberculosis and the white American and white American respectability. So the response was attuned to shaping American middle classness as the most desirable thing. And so people were taught to adopt American hygienic habits, bathing and so forth. Other middle class habits like sexual continence, abstemiousness with alcohol, limitations on family size, dietary habits, big time, and complying with the medical system as it was at the time. And the point I want to make is that distinction making doesn't end in the roughly middle of the 20th century when tuberculosis begins to be much more controllable because of the advent of antibiotics. So in fact, today, we still have this phenomenon that a decent and full life is less available to you if you're Black or Hispanic in America. And I find it shocking in a country as wealthy as this one. I'm going to come to that in one of my questions. Let me just, before we go to these questions for the panelists, break things out into two pieces to what I see as this exclusiveness. One is our famous medical system, which, as everybody knows, isn't really a healthcare system, although we call it that. It's a system for management of diagnosis and treatment. It's financed in a capitated fee-for-service way. So, and payment usually occurs through an industry of rapacious middlemen who are, referred to as health insurance, and therefore, getting actually adequate care depends on status, depends on income or wealth, and those things are intimate, as we all know, intimately tied to whiteness in America. Second piece, the public health system. The public health system in America isn't allowed to talk about the real diseases of the American the body of the American public, the fact that 2.2 million Americans are behind bars, that 1 million million-ish, nobody knows the exact number, Americans are homeless, and millions more are housed at any one time, but unstably housed, aren't sure from month to month that they'll have a place to live. Tens of millions of children live in poverty. More than 30 million Americans don't even have that health insurance so that they can get adequate care. And all of these things are related. So all of these things are related to race, and they're the things that the public health system doesn't get to occupy itself with. So that's where I'm coming from. That's why I want to ask about belonging, or to take a term from the title here, about the divide. So of course, coronavirus is on everybody's mind, I guess, or if it wasn't, I just put it back there. Here's a worry of mine. Medical science has advanced unbelievably rapidly in the past 6 months. We were shocked back in the 1980s at how fast learning about HIV progressed. The knowledge about SARS-CoV-2 has been astronomically faster. We know so much that we didn't know in January. We also know there's a lot of medical knowledge. There are ways now that weren't even available in March, or weren't certain in March, to keep people from getting very sick. Dexamethasone, when to use ventilators and when not to use ventilators, proning people, I think I messed up that term, putting people on their stomachs, and convalescent serum, how to reduce transmission. So much more known now than a few months ago. But in the usual scenario, when medical science proceeds apace, there are treatments that benefit some people, particularly the ones who can pay, and not others. And so my first question for the panelists, I know that Michael has already told me he's not going to try to answer this one, but I would be happy for anybody to answer this one. If this is if history is predictive, if the advance of medical science produces treatments, maybe produces vaccines that are really beneficial but costly, what's going to be the effect on Black and brown Americans? Anybody? I know you don't have a crystal ball, but I'd like to know what you think.
Well, Phil, let me jump in first, because I think that the setup that you've sort of established is a really thoughtful one. And I thought I was going to respond in a particular way, but in hearing you lay it out, I'm like, okay, I'm going to go in a different direction. And I think, part of what has become even more apparent to me through COVID is I couldn't agree with you more that we have a healthcare system that's designed to treat sickness. It's not designed to create health. And we have a somewhat divorced public health system, and I'm going to put public system in quotations because there is no cohesive national system in the way that we think about healthcare delivery. And with that being said, I think that the intersection between public health and healthcare delivery and the importance of that intersection has become really acutely apparent during COVID. And I think that your notion of treatment is one that we can sort of look at in two ways. Until such time that we have definitive medication for COVID or a vaccine, we have to think about different ways to quote unquote treat COVID-19. And that's where I think the issue of stable housing, the issue of supporting food security, the issue of ensuring that people have ongoing income is so critical, because if someone doesn't have all of these three things, they can be as motivated as they want to be, but they won't be able to isolate safely. They won't be able to adhere to quarantine, and we'll never be able to bring this pandemic to an end. And so for us, I think that that has been um, the value of really looking at and diving more deeply into the data that we have available to better understand who's getting COVID, who's having to be hospitalized, who's dying because of COVID, and what can we learn from that to then design treatment regimens that really take into consideration the fullness of someone and not just the biology or the clinical aspects of a virus that we're learning about every day. So, and I think that that's something that doesn't get as much attention as it should, and that we talk about it in non-COVID times, you know, the importance of housing first when we talk about homelessness, when we talk about HIV, but never has it really been more acute than in the COVID-19 pandemic.
Thanks. And thank you for pushing back. Come to my class. Lilium, do you want to add?
No, I mean, I really agree completely. I think that, you know, we respond to disease depending on our vulnerabilities and depending on our place in life. And I think that, you know, traditionally poor people have poor health, and they're much more vulnerable to whatever is happening in terms of diseases that are going around. And I think that, you know, it's unfortunately, that's the reality. So I couldn't agree more with the commissioner and with you.
Thanks.
I will jump in.
Great.
I did say that, I mean, the reason I said earlier that I might leave this to the other two panelists is because they are the public health experts. I do income distribution stuff. But given how you framed it and given their responses, I mean, I do have a thought. And you use the word belonging and exclusion and belonging. I think what happens, and this is kind of an outsider's perspective. I mean, I'm not really involved in a public health person, but this is my impression, is that we, in our country, we attribute health problems typically to individual behavior often. People don't eat right, they don't exercise enough, they don't do various things. And so a lot of health problems we attribute to individual behavior. If they behave better, they do better. And often, the things that we want people to do to be healthy are more accessible to some groups than other groups because they cost money. They depend on where you live. They depend on what kind of job you have. They depend on do you have a job or not. So they depend on a lot of social forces which impact people differently. If you're Black and brown, you're less likely to be employed because of racist hiring practices in many cases. So we sort of expect people to behave, I'll say in quotes, properly, but then we structure a society that makes it more difficult for people in certain groups to behave properly, if you will, and belong, if that's what belonging means. So I think that may even happen with COVID, as let's say we do develop even better treatments or vaccines. How much will they cost? Will they be covered by insurance, right? And so I can imagine a time where we have treatments and they may be going to people who have more money and more income and things like that. And then if Black and brown folks are still getting sick, I can anticipate people saying, well, if they took the vaccine, if they did this, if they did that, when again, society may not be structured in such a way which makes that as accessible to them. So I think that's how I think belonging in your sense, I think, relates to what I was thinking about healthcare and public health.
And there certainly is a long tradition of that blaming the victim in America, right? Like you live in a densely populated neighborhood in extremely crowded housing, and there's no way to avoid contagion if somebody brings it home. but but it's your fault because you didn't practice the right kind of hygiene, or you didn't practice social distancing. And that's, I think that it's really hard in America to step away from that kind of thinking. It's comes so naturally to us. So let me ask, so I think the next question I was going to ask really draws on some of what you've all just said. Take my idea of there being diseases in the American public body. One of them surely is how many children live in poverty. So the latest data I could find indicate that something like a third of Black children in America are growing up in poverty, and about 28% of Hispanic children. And that just seems shocking. The GDP in this country is $20 trillion. I mean, that's 20 million, a million times. I can't even conceive how that looks, like $100, 20 million in $100 bills. I don't know what that looks like. And yet, a third of Black and Hispanic children are living in poverty. That seems crazy. So, and similarly in other areas, Americans killed by firearms are disproportionately Black. Americans who don't have health insurance are disproportionately Hispanic. Americans who are incarcerated are disproportionately Black, and way disproportionately, about 5 times more likely. Even in New York City, with our enlightened leadership and a very relatively liberal environment, the children of the infants born to Black mothers are more likely to die in infancy than babies born to white mothers. So how do we redress these kinds of racial divides how can we redress these kinds of racial divides? I mean, Michael, this is what you're getting at. Anybody?
I'll start with that one, I guess. Maybe that's kind of like kind of like here. I guess I'll first talk a little bit about how I see poverty.
Great.
Kind of old-fashioned, maybe. To me, poverty is very simple. If you don't have enough money to meet your needs, you're poor. I want to start there because recently, in the past, recently in the last 20 years or so, a lot of commentators on poverty have thought they write about it as if it's more about social exclusion or people don't have the right culture or they don't get married enough. I mean, there are all these factors about what poverty is, and it's just about not having enough money, right? Some of those things may be associated with it, maybe even to some degree cause poverty. I mean, it's cause the poverty complex, but poverty is not having enough money. I mean, that's how I see it, right? And so if you want people not to be poor, then give them money. Most of us get most of our dollars, I think, if we're not independently wealthy, by working, selling your labor in the formal or informal economy. But then if you depend on that way of getting people money, that depends on finding a job and finding a job that pays enough. And as I said earlier, the degree to which you can find the job varies depending on race and gender, because we have a society that often discriminates based on race and gender, right? And so if you want people not to be poor, then I've always advocated for a policy called universal basic income, at least in principle. I mean, it has some complications we could talk about, right? How to finance it, how to pay for it, things like that. But in principle, I think we should just give people money, right? Have the government give people a minimum income, whether they sell their labor or not. And the hope is that that can be high enough for them not to be poor, right? And then if they have earnings or make more income beyond that, there's probably going to be income tax still in place. So you tax that, but tax that at a rate such that they don't lose $1 in the minimum in the guaranteed income for each dollar they make in earnings, right? Because that maintains an incentive to sell your labor, right? So if you do this in a way that like is sensitive to work incentives, you can do this, at least in principle, I think, and I think maybe even in practice, as a way of addressing poverty, and you address it at the place where it exists. It's about money, right? Since we are talking about race and racism, I should probably mention, this is not an idea of mine, but it's an idea I should mention in this context around basic income. It's an idea of a colleague of mine, someone I know who's involved in this area, named Dorian Warren, and he's advocated something called a UBI Plus, right? And I mention it because of what we're talking about. So just this, I mean, it's a controversial idea, but I think it's interesting, right? So he comes out of the basic income movement, comes out of that movement from a background in racial justice. He's a political scientist, writes about racial justice and racism. And he wrote a paper a few years ago where he advocated what he called UBI Plus. And the plus is plus an amount that would constitute reparations, right, for Black folks. So it's a universal income for everyone plus an amount for reparations, right? Now that's controversial, probably, right, right. But because it's controversial and maybe hard to implement, right? But neither of those things means that it's wrong in principle, right? But for me at least, I think would be a way to address some of these problems.
Interesting. I mean, I think you're right. I think that the issue with racism in this country and with poverty in this country is that there are people who have been at a cumulative disadvantage for years and years and years. And so something has to catch them up. I mean, we cannot expect giving them a basic income and then everything is going to be absolutely wonderful. I mean, there's a lot of stuff that has to be set right. And I think, providing not just minimum, but beyond that, it's really important.
And I'm sorry, go ahead, please.
No, and I'll add, just from the health perspective and what's really become apparent during COVID, the fact that so many people, millions of Americans have lost their jobs during this pandemic and as a result have lost their health insurance, I really, begs the question, why do we still have employer-based health insurance when, because of, through no fault of their own, people are losing access to something that has been demonstrated to really help people remain out of poverty, remain out of bankruptcy, has mental health benefits, et cetera. So flawed as it may be. And so I think it's an opportunity for us to rethink what it is that we take for granted as being the norm and really interrogate how it then contributes to the types of inequities that we're seeing played out in health. The other thing I'll just say is, from a public health point of view, a number of years ago, I had my team do an analysis of what difference a $15 minimum wage would make on premature mortality. And what we found was that it saves lives, and it saves lives of people that are poor, Black and brown. And so beyond sort of the economic impacts of whether it be a universal basic income or whether it be a living wage, these have real life and death consequences for everyday Americans, everyday New Yorkers.
It seems, so I wonder if there's a way to think about making healthcare available for all as somehow part of the package of universal basic income, whatever it's called.
May I comment on that? I was going to actually make that point. I actually regard Medicare for all, or at least some kind of universal health insurance that's not tied to employment. I mean, to me, that to me is like an in-kind UBI. So that's actually part of a UBI. I don't think it's really distinct. And it's just that I think there are good reasons to not give that part in cash and then say, go buy whatever you need, because healthcare problems can occur, out of blue and cost a whole lot of money at once, right? And so I think having that structure more as like a Medicare for all kind of package or some universal system is a better way to do it than give people cash. But to me, it's really part of the UBI. So I make no distinction between those two at all. I'm not sure if all UBI people would see it that way, UBI proponents, but that's how I see it at least.
Well, and the same thing happens with housing, and the same thing happens with nutrition. I mean, those are really basic needs that just, it's beyond just giving them money. It's making sure that the money you're giving them can buy people an adequate nutrition, adequate health care, and adequate housing. Otherwise it doesn't make any sense.
So, Dr. Bourbeau?
No.
No, okay. So what I wonder about about a universal approach is, I mean, it goes dramatically against the typical American social welfare approach, which is means tested. So it doesn't matter if you're poor, you're going to get this, you get the healthcare paid for, and you get the universal basic income. Is that true at the highest levels also? So is it really everybody? Do we totally wipe out means testing because we'd really like to do away with means testing as a social, political construct? Or I'm looking for guidance here. How do you set that up?
So, I mean, in my experience, programs for poor people tend to be poor programs. And I think universal programs tend to be much better.
Yeah.
I think we have to find a happy way of doing that. I think people who have a lot should not benefit indiscriminately. But on the other hand, we should guarantee a basic minimum standard of housing, nutrition, and health for everyone. Just by the virtue that they were born with, in this soil, they should be entitled to that. And even when they come, they're born here.
If you've got a lot, you can get more, but everybody gets the basic thing.
It is. I mean, I think when you do it means tested, when only poor people get certain things, the way that philosophically and reality they have developed is that they tend to be poor programs that tend to be stigmatized, cut back, and never work terribly well.
Or state-operated programs like Medicaid, which we're fortunate in New York State. Medicaid is fairly generous by the low standards of Medicaid in America, but there are 14 states where if you are considered to be able-bodied and you're an unmarried adult, there is no Medicaid. There's no health insurance for you. Just sorry, you're out. You get sick, you're on your own. I was going to ask, I want to be mindful of time because we have to leave time for questions, to answer some questions. Let's say we have this system. So all these great ideas happen. So you're all going to wave your magic wands and we're going to get UBI plus, Medicare for all, housing for all. Okay, we're there. What else do we need? These get discussed in the lead up to presidential campaigns. They get discussed certainly in the context of coronavirus, at least in a place like New York, they get discussed. But what else? Dr. Bourbeau, you mentioned mental illness. I'm very concerned about the way that mental health resists incorporation in many settings, resists incorporation into the public health view. Environment and the environmental change, climate change. So what are toxic exposures? What are the other aspects of that affect Americans' health that you want to build into this system as you wave your magic wand?
Yeah, you know, that's a really good question. I, I think that we can't take the approach of if you build it, they will come
Hmm.
and help will automatically sort of manifest, right? For me, the way that I look at it is um, that missing element, in my opinion, is related to social cohesion, which goes back to what you said at the beginning. And it play I think of social cohesion as that interstitial fluid that kind of keeps everything together and creates a measure of homeostasis, in that it's a way of reinforcing behaviors that are shared by groups of people, and can sort of be forces to make healthy choices the default choices, as opposed to what poor people and people of color typically have now, which are false choices, right? We tell patients, eat right, exercise, but we don't take into consideration that, you know, they may live in communities where they fear being shot if they go out jogging, where there isn't a grocery store to be seen for miles. And so, to the degree that we incorporate social cohesion and the the amplifying effects it has on mental health supports, I think are incredibly critical, because I think we're a country that has, especially now, a significant amount of trauma, and collective trauma, individual trauma, and we don't have a coordinated system that really addresses that in a way that is supportive. We have systems that are punitive, that deal with mental health, you know, incarceration, for example. But to the degree that we build in social cohesion, you know, as my component of the magic wand in this new system that we would be building, I think that would be a way to reinforce social norms that could help support better health outcomes that don't just focus on physical health, but also take into account mental health.
I guess part of my magic wand. It's kind of I mean your question is like your question was premised on we already had these other things. But
Yes.
my magic wand is more so I can't help me to think about that, because my magic wand is really more about what might help get us these other things. What might help us get there, right? It has to do with politics, because these are really political questions, right? I mean, politics broadly defined, activism on the streets politics, but also electoral, right? And so I'm going to make comments about electoral politics. So I think that one thing I would like to see happen, my dream, right, would be to have, it's going to sound strange and out of left field, but why not make Election Day a national holiday, right?
Yeah.
Why not make it easy? Like, why not create a system where the registration to vote is the default, and you don't have to, like, you know, actually make an effort to do it, but it's done already in a sense. Not do it, right? I mean, because what I have in mind are efforts to suppress votes or make it harder to vote, and those efforts aren't random. They're targeted at brown people like me and black people, right? And so, and many people died trying to fight for votes, not just blacks, right? So I think we're in another, and voting, I know there are folks who don't think voting matters that much, or that can be debated. But let's expand it beyond where we are now and see, right?
Yeah, see if it matters.
Maybe more people could actually do it. See if it matters, right? So some of those, I mean, like sort of political things that make it like people should, like, voting should be easy, right? And And if you're going to err anywhere, don't worry about so-called fraud. I mean, that I don't like. There doesn't seem to be that much of that, right? So err making it easier and risk more of that, as opposed to making it harder to defend against fraud, is almost non-existent, right? So those are things I would actually advocate. Not tied to the basic income that much, but I think they're important as part of our political process that is supposed to be democratic. That's what we call it.
Yeah. Well, politics, I'm glad you brought this up, because all of this is intensely political, and not only because it's wrapped up with race, this inextricable thread in American history, but because it's controversial. So I hope we can continue talking about this. I'm going to let Mac Barrett pose some of the audience. There's Mac. Hey, that was magic.
Hey, everybody.
Whoa. Pose some questions that we're getting from the audience.
Yes. I'll read some questions to you from the audience now. Let's see. A question from Diane Kirshner. It's actually picking up on what you've been discussing. She says, so you're articulating in a way the platform of Bernie Sanders, as well as Andrew Yang. Yet they were not favored by the powers that be within the Democratic Party. What can be done to move these proposals beyond ideas?
I think what Michael was saying before, I think, voting and making elections accessible to everyone, or voting accessible to everybody, that's crucial. I think as long as you keep suppressing votes of people who think differently from what is seen as the mainstream, we'll never have change. Or change will be very difficult.
This question sort of follows up on that. It's from a person whose name I'm going to probably mispronounce. I apologize. Onyekachi Okiki asks, in your opinion, what is the role of politicians and government officials, and how much responsibility should they hold in this fight for efficient and equal healthcare for all?
Crucial.
Go ahead.
Go ahead.
Go ahead.
No, I mean, it's crucial. I mean, look, the political system at the end of the day controls the budget, and the budget controls where money is allocated and what happens and who pays for what. So as long as politicians don't see it as an imperative, and we don't make them accountable for doing that, that won't change. I mean, that's the bottom line reality. I mean, we have to elect people that are accountable and are committed to certain things. And that's the bottom line.
And this is, Michael, this is what you're what you're talking about. How do you make people accountable? Well, the only way to do it is if people vote, but really everybody, or nearly everybody, votes, right? That it's easy to see the political system as moving in its own way and tolerating this kind of malfeasance on the part of officials not doing anything about these problems when so few people vote.
I think voting is important, obviously, but I wouldn't dare. I mean, I think over the last, 2 months, we've seen people in the streets engaging in another kind of politics. I joined a couple of those, although I was terrified of getting COVID because I'm not 28. So I was a little worried. So I'm not at zero risk or near that, but I joined a few. So that's also a kind of politics too. I think all of that is involved. And apparently that's had some influence, at least in changing the discussion, even some influence legislatively, right? So I wouldn't just leave it at voting, but certainly voting. I think they interact, right?
Yes.
Yeah, and what I was going to add was I think that there's a role for all of us to change the dominant narrative and not to take the dominant narrative as the narrative. And I think that certainly in the time of COVID, questioning what we have in place and why it's still the norm. I think it's a useful entry into really helping lead people to a different way of visualizing a future that's more just. And I mean, as I say those words coming out of my mouth, it sounds a little bit idealistic, but in reality, it's not, because unless we start talking about the way in which we take care of people in a different way, we're never going to be able to move out of a society that values whiteness and privilege over everyone else.
And the changing the narrative is, I mean, I think, Michael, this is what you were getting at, yes, that one of the successes of politics of the street can be, even if the leaders don't change, and if they don't change their minds, but the story changes, the story shifts, the terms that are used. After Occupy Wall Street, it's almost 10 years ago, we started hearing about inequality. I mean, Michael, you and I have been talking about inequality in class, but you didn't read about it in the newspaper. And suddenly there it was. And so, yeah, there's a way to knit politics and narrative if it works, if the politics work.
We have a couple questions here to do with COVID and incarceration that I'll put together into a two-part question. The first part is, could you speak to the crisis of COVID-19 within the prison system? And also, what role can public health play in decarceration, given that jails and prisons are COVID hotspots?
So I think what we saw here in New York City was early on releasing a large number of individuals from Rikers who were at highest risk for COVID. And I actually don't know of any other jurisdiction that has done similarly. There may be others who do. And so I think that was a significant step towards addressing unnecessary risks and realizing that, a system of mass incarceration has multiple harms, certainly in COVID, that are avoidable. And then the second one is really working in tandem with our partners so that individuals and institutions have access to the type of PPE and preventive services that are needed in order to ensure that when there are individuals who are incarcerated, that it happens in the safest possible manner. And so I think that in this city, we have taken significant strides towards reducing the risk for people who are incarcerated.
And does anybody want to try the question of the role of health professionals in decarceration?
Well, the reality is that for many years, Rikers was the biggest place to place the people with mental illness. So that in itself, it's tremendous role. I mean, for mental health practitioners to have to, not to penalize people who are mentally ill, but to treat people who are mentally ill. The same thing with substance use and abuse. So I think that there's a huge role. I mean, we have to learn how to separate completely bad behavior because I'm ill from bad behavior because it's bad behavior. And I think we'll find that the numbers of people incarcerated would diminish immensely.
Yeah, it's a nice point. If we had a robust public mental health system, or more robust public mental health system, if some of the things that New York City has been trying were more widely done, and of course, much better funded, then it would be possible to move. I forget the percentage. Maybe one of you remembers. The state and federal prison system is the most common location for housing the seriously mental ill in America. Yeah. More common than hospitals or halfway houses or anything else. And so I wish I remembered the number. Some data don't stick in my head. But that's thousands and thousands and thousands of people who don't have to be in prison if there were a way to identify and treat them. And then, of course, there are more who aren't getting incarcerated, but therefore aren't even getting diagnosed or treated.
Yeah, certainly it's a vicious cycle where,
Yeah.
once there was, rightly so, deinstitutionalizing of individuals with mental health, there wasn't the accompanying supports in community to maximize individuals receiving treatment in community. We've made significant investments in the mental health system here in New York City, but nowhere near where it needs to be, and certainly nowhere near the kind of coordination that would really be most beneficial to maximizing the number of people that remain in their families and communities.
Question from Mariam Altara. Do you believe that the lack of representation of health professionals is a factor that causes health disparities in minority communities?
So I guess the question means the lack of the underrepresentation of minorities among health professionals. And
well, I actually took it to mean the lack of representation in government, people concerned with standing up for health professionals. It could be the other way though. And not like, whatever, however you take it.
So could you say the end of the question part of the question, the last piece?
Do you believe the lack of representation of health professionals is a factor that causes health disparities in minority communities? If you'd like to move to the next, that's fine too.
Let's think about that one and we'll go to the next one. Oh, Dr. Barmon, do you have an...
I will say that there are studies in the literature that have demonstrated better health outcomes when there's congruence in ethnicity and language between the provider and the patient. I think that being said, however, it doesn't absolve the healthcare system for needing to be more accessible with regards to anybody and everybody that's accessing services. And one of the things that we've done in collaboration with healthcare partners here in New York City is start tackling the issue of implicit bias in healthcare delivery and the degree to which it contributes to maternal mortality. Here in New York City, we have some of the highest maternal mortality rates in the country. And I think the fact that our healthcare partners have been open to starting the conversation about implicit bias is as important as increasing the number of doctors who are Black and brown. It's not an either or, it's a both.
It's an important, a recent study of medical students, this shocked me, found that 16% of them said they thought or suspected that Black Americans don't feel pain the same way that white Americans do. So, yeah, I mean, so talk about, no, to me that's a sign of a need to proactively change the narrative within the educational system in some of the health fields.
Absolutely.
We've got time. Sorry to cut you off. What was that?
You need to start in kindergarten, I think. It's a long process.
And just one last question from the audience here. I apologize to those whose questions we aren't able to get to. A question from Paul Pfeiffer. Can the panelists speak briefly to the efforts they're currently involved in to address the needs of underserved people navigating the system now?
I guess I can start. So for a long time, I was involved in an organization called Universal Basic Income that started a long time ago that was it was an organization of activists and academics, or people who were both, trying to promote discussion of UBI, get the idea out there. This was started a long time ago. What we tried to do back then is now happening, right? It's much more discussion than when we started. And because of that, I've moved a little bit more into like I'm trying to work with groups who are looking at UBI from a more activist point of view. So they're actually trying to get it not just talked about, but actually get it put in place at the city level, at the state level. There's a group called, I think it's called Income Support, that I have some connections with, and they're trying to get the current discussion in Congress right now on another relief package to include temporary basic income that they hope evolve into a permanent one, right? So I've moved from more, I'm trying to move more from like promoting discussion about it to doing whatever I can to actually make it happen in the world. But I've been involved in that area in some way for about the last 20 years.
I can go next and say that there's lots that's happening at the health department, but I think what I'll talk about is the process of Take Care New York. And basically, we are engaging every 4 years intensively, and then throughout the intermittent years, we conduct community conversations around what matters to community members in terms of health and health outcomes, and then engage in a process of prioritization so that in collaboration with community, we determine what are the areas to take on for action. We then bring them together with either academia, foundations, or other sister agencies to really make substantive changes in their communities. We're actually going to be kicking off another series of Take Care New York conversations. And in this particular iteration, one of the things, and this sort of brings us back to the beginning, we're talking about how generational wealth contributes to health outcomes and how we can together build income streams to provide more resiliency in communities as a way of addressing health inequalities. And so it's a new area for public health, at least our public health department, to be involved in, and one that I'm really excited about because I think it broadens the conversation about what creates health.
Right, and I think what we said at the beginning as well is that we have a sick care system, and we have to transform it into a well care system, and we have to emphasize people not getting sick as opposed to just taking care of them when they are sick. And I think that would be a tremendous transformation, but that implies a lot of primary health care, that implies a lot of nutritional support and housing and a number of other things that we have mentioned.
I think that's probably it, right, Mac?
That's it. And I think Misha will now make an announcement about the breakout room.
So Misha, can I just have a second to thank the panelists? Wow, you guys you're all terrific. Thank you so much.
Thank you.
Thank you.
Misha.
Hi, everyone. So thank you all. Thank you to the panelists again, and thank you all for joining.